Welcome back to the Deep Dive. Today, we are taking a really close look inside one of the most complex organs in the body, the heart.
That's right.
Specifically, we're focusing on genetic cardiomyopathies. These are heart conditions that are basically hardwired into our DNA.
Right. Our sources today are taking us deep into the genetic factors that either cause or really modify the traditional forms of heart muscle disease we talk about.
Like hypertrophic, dilated, restrictive.
Exactly. And arrhythmogenic cardiomyopathies. And the list of genes involved, it's exploding.
And what's really striking is just how common this is. I mean, more common than we used to think.
Oh, absolutely.
The sources confirm that for something like dilated cardiomyopathy or DCM, if there's no obvious cause, like a heart attack or alcohol abuse.
Yeah, the idiopathic cases.
Right. We now estimate that a genetic factor is the culprit in at least 30% of those patients. That's a huge number for unexplained heart failure.
It is, and it completely changes how you have to approach a patient's family history.
You can't just ask about heart failure anymore.
No, you can't. You have to dig deeper. You have to ask about, say, sudden death in the family, which, is so often just written off as a heart attack.
Ah, right.
Or you ask about atrial fibrillation starting in someone's 40s, or needing a pacemaker by middle age, even things like muscular dystrophy. These are all little red flags.
Okay, let's unpack this. Let's start with the basics, the genetic architecture. How are these diseases usually passed down?
For most of them, the main pattern is what we call autosomal dominant, AD.
So you only need one copy of the faulty gene.
Exactly. One copy is enough to potentially cause the disease, but it's not the only way. You also see autosomal recessive, X-linked, and even matrilineal inheritance through mitochondrial DNA.
So when we say a genetic variant, what's it actually doing inside the heart muscle cell that causes it to fail?
Oh, well, you're usually looking at one of two things. Either a missense variant, where one amino acid gets swapped for another, or a truncating variant, which basically cuts the protein short.
And those errors cause problems in a couple of key ways. The first one is called the dominant negative mechanism.
That name. It sounds pretty bad, and it is.
Yeah.
So think of it like this. You have one good gene making a normal protein, but you also have the mutant gene making a bad abnormal protein.
Okay.
In the dominant negative case, that bad protein gets into the machinery and actively messes up the function of the good protein. It's a saboteur. It's actively breaking things.
So it's not just useless, it's destructive.
Yeah.
What's the other mechanism?
The other one is haploinsufficiency.
Haploinsufficiency.
Yeah, this usually happens with those truncating variants. The protein gets cut short, it's unstable, and the cell just gets rid of it. So the problem here isn't sabotage. It's just not having enough of the right building material.
A supply shortage.
Exactly. The heart muscle just doesn't have enough of that critical protein to work properly. And what's important, especially in dilated cardiomyopathy, is that you can have both of these problems happening at the same time.
That sounds incredibly complex. I mean, if a patient has heart failure, where do you even begin to look for the gene?
That is the central challenge. You're dealing with massive locus heterogeneity.
Meaning lots of different genes can cause the same disease.
Exactly. And then within each of those genes, you have allelic heterogeneity. Thousands of different specific variants. It makes testing, very complicated and expensive.
So the whole idea of hunting for one single bad gene is changing.
It is. The field is shifting. We're now starting to use tools like polygenic risk scores.
Which look at the combined effect of lots of smaller impact genes.
Right. It recognizes that heart disease is often a continuum of risk, not just an on-off switch flipped by one single variant.
And that gets us to this idea of incomplete penetrance.
Yeah.
Just because you have the gene doesn't mean you get the disease.
That's the million-dollar question in this field. The actual disease, the phenotype, it's almost never there at birth, and for some people, it might never show up at all.
You could be a carrier and live into your 80s completely fine.
Completely fine, which just proves that our genes aren't our destiny. There are other things, epigenetics, environment, lifestyle, that are powerful modifiers.
And one of those modifiers that keeps coming up in the sources is sex.
Yes, sex matters a lot. For most of these cardiomyopathies, the penetrance, the chance of getting sick, and the severity of the disease are generally worse in men.
Interesting. So with all this complexity, where does genetic testing actually provide the most value right now?
Right now, its greatest value is for the family. It's preventive.
Cascade screening.
Exactly. We find a pathogenic variant in one person. We can then test their close relatives. We can find the asymptomatic carriers and get them into monitoring with, a simple ECG and an echo. And it's also critical for finding those few diseases where there's a specific targeted therapy available.
Okay, let's pivot to one of the big ones. Hypertrophic cardiomyopathy, or HCM. This is the one you hear about as a leading cause of sudden death in young people.
Right. HCM is defined by a thick left ventricle wall that isn't caused by something else, like high blood pressure. And it's usually not a uniform thickening. It's often concentrated in the septum, the wall between the two ventricles.
And what's happening at the microscopic level?
You see total disorganization. The muscle cells, the myocytes, are enlarged and just misaligned. They lose their normal, efficient, brick-like structure. And genetically, we know the main culprits are variants in the sarcomere genes,
The contractile machinery itself?
the engine of the heart muscle. These variants are found in about 40 to 50% of HCM patients.
And is it like DCM with tons of different genes?
Well, there are many, but it's actually much more concentrated. About 80% of all identified cases come down to a variant in just two genes.
The genes.
MYH7, which is the beta-myosin heavy chain, or MYBPC3, which is myosin-binding protein C.
And even with those, the disease doesn't show up right away.
No, it's what we call age-dependent penetrance. It takes decades to develop. For instance, people with the common MYBPC3 variant usually don't show hypertrophy until they're around 40. But get this, 30% of those carriers are still totally free of hypertrophy even after age 70.
Wow. So some protective factors at play there.
A very strong one.
Now, the big mechanical problem in HCM is obstruction. How does that work?
So when that septum gets really thick, it narrows the path for blood leaving the heart, the left ventricular outflow tract, or LVOT.
Right.
And as the heart squeezes, the blood rushes through that narrow space, and it creates a kind of drag force that pulls the mitral valve leaflet forward until it smacks right into the septum.
Creating a blockage.
A physical blockage. It's
Yeah.
a phenomenon called systolic anterior motion, or SAM.
And this obstruction isn't always there, right?
Exactly. Only about 30% of patients have it at rest. But in another 30%, you can provoke it with things that make the heart chamber smaller, like dehydration or certain physical maneuvers.
So because we can't really predict the course of the disease from the gene alone, treatment has really focused on the symptoms, the phenotype.
That's been the foundation. First-line drugs are beta blockers and calcium channel blockers. They don't fix the gene, but they slow the heart rate, help the stiff muscle fill, and reduce the force of contraction to lessen that obstruction.
But the sources are highlighting a huge conceptual leap forward here with a new class of drugs.
Oh, this is a genuine paradigm shift. We're talking about small molecule cardiac myosin inhibitors.
Mavacamten.
Mavacamten is the one that's FDA approved, and another called aficamten is on the way. And what these do is they target the actual molecular problem, that hypercontractility.
So instead of just slowing the heart down, you're dialing down the overactive engine itself.
Precisely. They're like molecular brakes,
Right.
and they are incredibly effective, to the point where some patients who are heading for surgery don't need it anymore.
Is there a risk?
There is. They're powerful, so you have to watch out for making the heart too weak. A transient reduction in ejection fraction is the main thing to monitor.
And if the drugs don't work? For that, what, 5% of patients?
Then you move to procedures. Septal reduction therapy. The gold standard is surgical myectomy.
Where a surgeon literally goes in and shaves away the excess muscle.
Correct. It's been around for 60 years and it's highly effective. The alternative is alcohol septal ablation, where you basically induce a tiny controlled heart attack to kill that obstructive tissue.
What's the main complication for those?
For both, because you're working right next to the heart's electrical system, you can cause complete heart block. That means needing a permanent pacemaker.
Okay, let's talk about the scariest part of HCM. The risk of sudden cardiac death. How do you stratify that risk?
Well, first, the baseline risk is thankfully low, less than 1% per year, but certain things really raise the alarm.
Like what?
A prior cardiac arrest, obviously, or fainting during exercise, a strong family history of sudden death. On an MRI, seeing an apical aneurysm, or if the heart wall is just massively thick, like over 30 millimeters, or if the heart's pumping function is weak.
So when you see those risk factors, is it an automatic decision to put in an ICD, an internal defibrillator?
Not at all. And this is where it gets incredibly difficult. We use risk calculators, but honestly, their predictive value is low. A lot of people get these devices and never need them.
And the devices aren't risk-free.
Far from it. Infection, broken wires, inappropriate shocks. It's a huge deal, especially for a young, active person. So this is where shared decision-making becomes absolutely essential.
You're not just checking boxes on a risk calculator.
No. You're having a deep conversation about risk, anxiety, and what this life-altering device means for a 25-year-old athlete. It's a judgment call.
Speaking of athletes, the advice on exercise has changed, right?
Dramatically. It used to be a blanket ban on competitive sports. But recent studies just haven't shown a link between exertion and triggering these dangerous arrhythmias, so now it's another shared decision, moving away from that strict prohibition.
Let's shift now to dilated cardiomyopathy, DCM. The heart is enlarged and weak.
Right, and familial clustering is really high, around 30 to 40%. And when you talk about the genetics of DCM, one gene just dominates the conversation.
Like Titan.
The giant protein, exactly, TTN. It's essential for the sarcomere structure. And truncating variants in TTN are the single most common genetic cause of DCM. Up to 25% of all familial cases, it's the first place you look.
And we see that sex difference again with Titan.
Very clearly, men with these TTN variants develop cardiomyopathy a full decade earlier, on average, than women with the exact same variant.
Now, for some of these diseases, it's not the weak muscle that's the first problem. It's the electrical system.
This is a critical point that changes everything about management. We see this with defects in nuclear membrane proteins, like LMNA.
Okay.
These variants cause a huge number of arrhythmias and conduction problems, heart block, often years before the heart muscle itself looks weak on an echo.
Wait, so the rhythm problem comes first?
The rhythm problem is the lead story. It seems that when the nucleus's structural integrity is compromised, it just wreaks havoc on the cell's electrical signaling.
And that means the genotype, knowing the specific gene, drives the treatment.
Absolutely. If a patient has a pathogenic LMNA or FLNC variant, they are in a different, higher risk category. You would consider putting an ICD in them much, much earlier, maybe even before their ejection fraction drops to that classic 35% cutoff. The sudden death risk is just that high.
We should also touch on arrhythmogenic cardiomyopathy, ACM.
Right. This is caused by defects in the desmosomes, the glue that holds heart cells together. When that glue fails, the cells detach and are replaced by fat and scar tissue.
Which is a perfect setup for arrhythmias.
A terrible setup,
Yeah.
highly arrhythmogenic. And while we used to call it ARVC, focusing on the right ventricle, we now just say ACM because we know it often affects the left ventricle, or both.
Okay, finally, let's talk about the curveballs, the metabolic diseases that look like cardiomyopathies.
The pseudohypertrophy diseases. Yeah, these are cases where the heart wall looks thick, but it's not because of excess muscle, it's because abnormal stuff is being stored inside the cells.
And finding them is key because they actually have specific treatments.
Right, and the classic example is Fabry's disease.
Which is an enzyme deficiency.
Exactly, a deficiency in alpha-galactosidase A. This causes a fatty substance to build up everywhere, skin, nerves, kidneys, and the heart. But we can treat it.
And the treatments are not cheap.
Not at all. Enzyme replacement therapy costs over $100,000 a year. There's also an oral drug, miglustat, for some patients. The cost just underscores why getting that genetic diagnosis is so vital. It unlocks these incredibly expensive but life-changing therapies.
And then there's Danon disease, which sounds just devastating.
It is an X-linked defect in LMP2. It causes massive hypertrophy very early in life and progresses incredibly fast to end-stage heart failure. But the reason it's so relevant today is that it's a major target for gene therapy.
So there are active trials trying to deliver a functional copy of the gene to the heart.
Yes, using viral vectors. It's really the cutting edge.
Okay, so this has been an incredible deep dive. To sum it up, while we still treat the symptoms, the phenotype of heart failure, genetic testing is becoming a really critical clinical tool, not just for family screening, but for actually predicting risk.
If you connect this to the bigger picture, yeah, the whole field is changing. We have drugs like mavacamten that treat the mechanism of the disease, not just the symptoms. But the future, as we see with the Danon trials, is in genotype-specific treatments, fixing the actual source code.
That leaves us with a provocative thought for you, our listener. We've talked a lot today about incomplete penetrance, why some people with a gene variant get sick and others don't. Given the consistent evidence that sex acts as a biological modifier, especially in HCM and Titan DCM, how will future therapies need to be tailored? Not just to the specific gene, but to these other biological factors to manage a person's risk even earlier in their life.
It really suggests we're on the cusp of truly personalized cardiology.
We'll see you next time on The Deep Dive.